my talk. I'll be presenting penetrating keratoplasty, a savior in distress. So till now, what we have seen is all the different procedures, different things which have been mentioned, suturing procedures, use of glue. But yes, penetrating keratoplasty at the end comes as a savior in distress when all the things fail. So as we all know, ocular trauma is a very important cause of unilateral blindness, especially in young people, male-female ratio being 4:1 because of the occupational part, because of their being more outdoor. Infectious keratitis, as already mentioned, is also a very frequent cause of emergency hospital admissions, and identifying causative organisms promptly is very important to avoid vision-threatening outcomes. Otherwise, things go downhill. Common pathogens including staph, Coagulase negative staph, Pseudomonas, filamentous fungi, Canthamoeba. These all are the things which lead to acute emergencies in infectious diseases. Post-LASIK microbial keratitis is also of concern if it is not being managed conservatively and it is going downhill. A cosmetic surgery usually going downhill becomes very difficult to manage. Then you need to have something to do in hand, and ultimately keratoplasty comes into play when everything fails and corneal melting occurs. So when these situations go downhill, what do we think that whether the line of therapy was wrong or inadequate therapy was there, or some kind of a drug resistance of toxicity is playing a part? So unable to understand, you rethink and rethink. Now in the thing, perforations which has been discussed, variety of perforations do come, smaller perforations as was already discussed. If it is less than 2 millimeters, you do a gluing. But indication for suturing is usually for perforations greater than 2 millimeters, or there is a displacement of the flap, or there is a loss of tissue. If there is a tissue loss, you can go for a conjunctival patch graft or a Tennant's patch graft, smaller perforations. If the perforation is even smaller, you can have an amniotic membrane graft option apart from the chemical injury, its use in chemical injuries. Now this patch graft is very important when the perforation is more than 3 millimeters and direct suturing is not very feasible. Even if you do not have the corneal tissues, you can suture it with a sclera. And suturing at this point becomes very important because usually the location of the tissue loss is important, whether it is centrally located or is it eccentric, because the repair may have a long-term visual outcome later on because of astigmatism and all. But patch graft comes into play when the perforation becomes larger than 3 millimeter and having a tissue loss. Collagen cross-linking is used in those cases where you have infectious cases which are not responding. You give a try for that before going into resorting for penetrating keratoplasty. So when you resort to penetrating keratoplasty, as you all know, either it can be tectonic therapeutic or it can be an optical one when the things have healed up. Though resorting to penetrating keratoplasty, it's not a procedure devoid of risks. Risk factors of risk of graft rejection is always there, with a high risk factor of young recipient. If there is a pre-existing more than 2 quadrants of vascularization, if you have used a large diameter corneal graft for a larger corneal melt or a larger perforation, if there is a pre-existing glaucoma or a presence of a pre-existing inflammation. These all factors, apart from resorting to penetrating keratoplasty, have a greater chance of graft rejection in future. Penetrating keratoplasty is not an easy thing to go, and you have intraoperative challenges while doing the surgery. Trephine related, either you have irregular trephining of the host or the donor tissue. You can have inadvertent surgical trauma to the ocular tissues while you're doing, because once you are resorting to this procedure in those corneal emergency cases where things have not gone well medically, they are very friable. So inadvertent surgical trauma to ocular tissues do occur. Anterior chamber hemorrhage can follow after the trauma to the iris by the trephine or while debridement of the tissues. Even expulsive suprachoroidal hemorrhage, which is one of the greatest risks because it's an open glow while you have opened the host. The risk factors are more often the elderly patients or having atherosclerosis, or they have a sudden rise of IOP due to sudden coughing or something. So this is a risk factor when we are dealing with penetrating keratoplasty. It's not devoid of postoperative complications in the early phase where you have suture-related complications, delayed epithelial healing, chances of infections, postoperative spike of IOP, and a primary graft failure. In the late phases, you can have wound dehiscence, formation of cataract, glaucoma being very common, astigmatism very common. Graft vascularization can occur depending upon the pre-existing quadrant of vascularization. And in later phases, if the patient is more prone to graft rejection, even it can go to graft rejections. So it's not devoid of postoperative complications. So resorting to penetrating keratoplasty suddenly shouldn't be the option, but it should be the distressed option. There can be a primary donor failure itself where the graft had never been cleared postoperatively due to an unhealthy donor endothelium, or due to the surgical trauma induced while placing the graft. So primary donor failure can occur even if you have done a corneal transplantation. Postoperative management is very meticulous because you have to be very careful in the postoperative course. You have to see the integrity of the wound and sutures, status of the surface, anterior chamber activity, what's the IOP following in the postoperative course, signs of any infection or rejection. Those things are to be followed up very meticulously along with the routine postoperative medications. Graft rejection, as I told you, that it's always there, the risk of graft rejection is always there. Every graft reaction does not proceed to graft rejection if identified timely. Definitely, it can be the graft can be preserved. So, in the end, I would say that definitely you have this armamentarium of penetrating keratoplasty with you when all the things fail. But yes, resorting immediately to penetrating keratoplasty is not very cakewalk. It is full of complications, full of meticulousness, full of things to be cared of. But yes, when no other options are there, it is the only rescuing thing which you have to carry along in the situation of corneal emergencies where you are not being able to do anything with any other procedures. So thank you with this. And with this, I think we come to the end of this session.